Yes, it's that time again. Your favorite shill for the medical industrial complex is doing another Puscast for April 15th through 30th, 2010. Now, time for the usual hodgepodge of babble that I need do because this is, hey, CME accredited. And since it's CME accredited, I have to mention my conflicts of interest. Actually, none. The only thing I've ever accepted from a drug rep or a pharmaceutical company is a Fleet Cinema. And it's still in the box. Thank you for asking. But when you're done and it's CME accredited, take the online quiz and get a half an hour free CME. Thanks, as always, to Legacy Health System. Actually, I think it's just now Legacy Health. It's getting shorter and shorter. As always, it's not called Persiflager's Puscast for nothing. This podcast will contain snide comments, sarcastic asides, short rants. Don't complain that I didn't warn you. You don't like it, go listen to another podcast. Now, join my multimedia empire. Go to moremark.squarespace.com because, as you know, the world needs more Mark Crislip. Nothing worse than false modesty, huh? Now, go to iTunes. Write me a glowing review. It's so important. You can't believe how important it is to get glowing reviews on iTunes. And if you want, and you have an iPad or an iPod or an iPhone, purchase the infectious disease app. Everything you want to know about infectious diseases. Well, not really, but everything I want to tell you, which is probably more important. And now we shall move on to the literature. Don't forget the references are available online. I know I'm a cynic, but the Infectious Disease Society of America has suggested that we develop 10 new drugs by 2020. We are, of course, sliding into the post-antibiotic era. The Infectious Disease Society recognizes this issue, which is serious. We are running out of drugs. And by the time I retire, I'm likely to die of a resistant infection. My theory, as you've heard before, is that doctors always die of their specialty, which is why I am glad I am not an obstetrician. I still can't say it. It's my third take. Obstetrician. Blah, blah, blah. OB-doc. There we go. I can't say the word tonight. Anyway, like any good Soviet-style 5-year plan, or in this case, a 10-year plan, they say we need more antibiotics, and indeed we do. Somehow, I think it would be nicer if everybody who wrote this didn't have conflicts of interest from one pharmaceutical company or another. I mean, of the 9 authors, they report 80 potential conflicts of interest, which is just mind-boggling. I know several of these physicians, and they are honorable people and good physicians, but still, 80 conflicts of interests from 9 doctors saying we need more antibiotics. I'm sorry, I just have trouble taking them seriously. Well, flu season has passed, but we learned something, and the flu seasons go away because we get to look at the data and see what happened. For example, whilst pregnant women represent 1% of the population, pregnant women accounted for 5% of the deaths from H1N1. Pregnant men, as always, were spared. One of the things that was associated with survival in pregnant women was a delay in receiving Tamiflu for their disease. Compared to patients who got their antiviral therapies early, 56.9% of women who got their treatment late needed the ICU, compared to 9.4% who didn't. Women who were treated late had 11 times the risk of mechanical ventilation, 56 versus 5%. And only 1 death occurred in a patient whose treatment was begun within 2 days of the onset of symptoms, while those who had late therapy were 54 more times likely to die than those who received early therapy. Third trimester had higher death rates than second trimester, had higher death rates than first trimester, and of course had higher death rates than the 0 trimester. I anticipate H1N1 will come back, and it's always been a bad disease in pregnant women. This study out of JAMA confirms that. Of course, I'm old school. It's better to prevent an illness than to get it. An ounce of prevention is worth a pound of cure. Or as I've said many times, an ounce of perversion is worth a pound of pure. And there was a study that looked at all the CDC recommendations and studies over the last couple of years in an attempt to see what non-pharmacological interventions were effective in preventing the transmission of influenza. And they found, hey, hand hygiene worked. Hey, covering your cough and sneezes decreased the spread of flu. Who would have thought not spewing influenza into the air would decrease the spread? Use of hospital-type surgical masks was also effective in decreasing the spread of flu. And that decreasing crowding also decreases the spread of flu. Unfortunately, theoretical constructs suggest that if you decreased air travel by 99%, given the infectivity of influenza, you would not alter the spread of the disease worldwide. Bummer there. But wash your hands, cover your cough, don't sneeze on people, wear a surgical mask, and stay out of large crowds. Those are ways to prevent you from spreading influenza or acquiring influenza. I recently had my 53rd birthday, so I'm closer and closer to being elderly. That's defined as greater than 65. And the problem with being elderly, besides the fact you have to yell at kids to get off your lawn, is that you don't respond as well to the influenza vaccine. To overcome that problem, there's been a recent release of a high-dose inactivated influenza vaccine called Fluzone High Dose. This contains 180 micrograms of influenza virus antigen compared to 45 micrograms in the standard dose. What can you say about this particular influenza? Well, in older people, 65 and above, who received this vaccine had higher titers than them what didn't. And higher titers are, in some studies, associated with protective against developing clinical influenza. Now, we do not have trials to show this has increased efficacy against influenza, but a higher titer should lead to better protection. So it would not be unreasonable in your geriatric population, it's only 12 years away, to give them the high-dose vaccine. I think it's reasonable. And it's certainly been demonstrated that one of the big problems with the elderly is they do not mount a response to the standard vaccine. This may be a way to have an improved vaccination in the elderly. There are two interesting classes of antibiotics. One is the macrolides, which probably takes the edge off of inflammation and helps decrease mortality in a variety of sepsis studies. The other is minocycline, because the tetracycline classes of antibiotics, including minocycline, can affect T cells. And there's some old studies from the 50s to show better outcomes in pneumococcal pneumonia of tetracyclines as compared to penicillins, maybe in part due to the fact that they're somewhat immunosuppressive. This study looked at minocycline and its effect on HIV infections and human CD4 cells. And the minocycline, and here I'll quote, mediated a dose-dependent decrease in CXCR-tropic HIV infection and decreased viral RNA after infection with HIV. And so this is interesting because minocycline in this study decreased expression of activation of CD25 and proliferation markers and reduces secretion of cytokines, including interleukin-2, interferon gamma, and TNF. Other markers went up and other markers went down, but the overall effect of minocycline was to decrease HIV replication due to its immunomodulatory effect, not by direct suppression of the HIV virus. Now, we don't have clinical trials yet, but it's an intriguing study and not the first to show that there's beneficial effects by both tetracycline class and by macrolide classes of antibiotics in blunting the immune response in a positive way, and in this case, an HIV positive way. So you may not be aware of a guy named Wakefield. He published an article in The Lancet that related the use of the MMR vaccine to the development of autism. It turns out he kind of made up a lot of his data, shall we say, and the article has since been revoked from The Lancet as a useless piece of crap. However, because of his made-up study, vaccination rates with the MMR plummeted in Europe and in Great Britain, or not so Great Britain anymore. Because of the decrease in measles vaccination, measles has become epidemic in Europe again. Now, Americans sometimes go to Europe. God knows I'd like to go back to France. And in 2008, an intentionally unvaccinated 7-year-old boy went to Switzerland, and he got measles. And he returned to San Diego and caused an outbreak of measles with a total of 839 exposed people and 11 cases of measles, all in unvaccinated children. And it included the hospitalization of an infant too young to be vaccinated. The epidemic was finally brought under control by aggressive vaccination, and an aggressive outbreak response resulted in the epidemic fading away at a cost of a little over $10,000 per case. Most of the cases occurred in those who were unvaccinated intentionally and were in either public, charter, or private schools, and they also tended to occur in upper socioeconomic areas. It's interesting that 48 children were quarantined at a cost of about $775 per child. I would like to encourage those families to find the index case and ask for their money, because if he'd been vaccinated appropriately, of course, this would probably not have happened. And I cannot emphasize this enough. There are now multiple studies to show no relationship whatsoever between the MMR and autism, except for one study in Poland to show that receiving the MMR was protective from developing autism. Probably not related, but interesting nonetheless. There are some things that are just hideous. So this lady dies, and she donates her corneas, her lungs, her liver, and both her kidneys. Oops, she had rabies. So what they tried to do, of course, was prevent the development of rabies in the patients who had received these organs. So they treated them with sedation, with anti-rabies immunoglobulin, with vaccination, with deep sedation, as well as ribavirin and interferon. Of those who got the kidneys and the lungs, died of rabies. The liver person did not, but had been vaccinated in the past against rabies. Both the corneas were removed and replaced. They survived. The corneas, however, did not have rabies identifiable in the tissue, so maybe it wasn't present at the time that the patient died, and that's why they didn't get rabies. But it would appear that if you get rabies-infected tissues, even that therapy, which has been associated with one survivor, may not be all that good, given the number of deaths. And I wonder if that was the genesis of the Scrubs episode with a similar plot line. I don't know. So, as some of you may or may not remember, several years back, the Infectious Disease Society of America was sued by the Connecticut Attorney General for their Infectious Disease of America guidelines for the treatment of Lyme, because the IDSA says ain't no such thing as chronic Lyme, and it's not supported by the scientific evidence. Well, they tried to bankrupt the IDSA, and there are no doctors who make less money than ID doctors. So the IDSA, in their wisdom, settled. And part of the settlement was that they had to re-review the guidelines by a new panel that was selected by someone that had no dog in the fight, and that everybody who reviewed the guidelines was not to have any conflicts of interest. So that was done. And what they found was the guidelines are fine, that the science does not support chronic Lyme disease as a clinical entity, nor the treatment of chronic Lyme with prolonged courses of antibiotics. Specifically, and I think most importantly, that if you have symptoms blamed on chronic Lyme disease, arthralgias, fatigue, cognitive dysfunction, it is, quote, clinically imprudent to make the diagnosis of Lyme disease because these are non-specific findings, end quote. And they often have other underlying medical problems, such as MS and endocarditis, which have been mistakenly diagnosed as chronic Lyme. So, the IDSA, when reviewed by physicians who did not have a dog in the fight, was found to have scientifically validated and appropriate recommendations. Next up, water is wet, fire is hot. So when new drugs are released, they're often tested in skin and soft tissue infections. One, because skin and soft tissue infections are common, and two, they're of low mortality, so the risk to the patient is not that high, unlike, say, treating sepsis. So often new antibiotics are released with skin and soft tissue as the major clinical trial to show efficacy, and then that data is extrapolated to other diseases, such as pneumonia, endocarditis, intradermal abscess, where the clinician says, well, it worked for the skin, it should work there. So what these people did is they went back and looked at all the clinical trials that were used for the approval of new drugs based on skin and soft tissue infections and did a meta-analysis on them. And guess what? You betcha the studies stank on ice. Quote, only 30% of trials required both local and systemic signs of infection for inclusion in the trial, and less than half reported patient comorbidities, and only 53% provided a specific definition of cure. And these were a variety of studies used to test drugs such as linezolid, ertapenem, daptomycin, tigecycline, dalvabansin, and ceftobiprole, and telavancin. As they say in the conclusion, quote, our meta-analysis of current trials evaluating antimicrobial therapy of skin and soft tissue infection reveals substantial and significant shortcomings of the data provided. This in turn limits the applicability of the results to clinical practice, end quote. And the important thing of all these new drugs was that none of the studies showed superiority of the tested agent. I mean, I've always known as a clinician that the studies used to approve new agents were always suboptimal, and I always assumed it was because of the morbidity associated with testing it in more ill populations, especially if the drug didn't live up to its expectations. And we are still mostly stuck with new agents in looking at the MICs, guessing at the drug levels, and crossing our fingers. So, what are the issues with secondhand smoke besides the fact that it makes the room stink? It's kind of like farting in public. This study looked at the risk of developing symptomatic chronic sinus congestion and found that exposure to secondhand smoke increased your risk. The risk in a public venue was low, with an odds ratio of developing symptomatic disease of about 0.148. If you were exposed in the home, however, the rates went up with an odds ratio of 1.69. And if you went to a private function, the odds ratio went way up to 2.6. They figured that if you went to all the above, home, private functions, and public areas, your risk of developing symptoms from secondhand smoke would go up to an odds ratio of 2.03. So if you have a lot of exposure to secondhand smoke in public, home, and private, you would see perhaps an 8-fold increased risk in chronic rhinosinusitis. So there may be an issue there with chronic secondhand smoke exposure. The most interesting thing is who sponsored this study. It was sponsored by the Flight Attendant Medical Research Institute. I remember when I was young how smokers would stink up the whole airplane, so I can understand how flight attendants would be interested in the health risks of inhaling other people's recirculated secondhand tobacco smoke. I'm not really sure what to make of this study from the Annals of Internal Medicine. This was a study out of France where they did MRs with angiography within 7 days of admission for any patient who had suspected endocarditis. Now, it's known that there are often embolic events that are subclinical in this disease, and this study confirmed that. They found that cerebral lesions on the MR were common. They found them in 82% of the patients, including 10 silent aneurysms. And the vast majority of patients who had these were not symptomatic, which is not surprising either. Now, what's curious is that although they shifted the diagnosis of endocarditis clinically from suspected to definitive on the basis of Duke criteria, the lesions on the MRI being embolic phenomenon, they also changed plans in about 24 of the 130 patients, including an alteration in surgical plan, where 14% of patients didn't have the surgery that they were on track to have because of the fear of bleeding. And this is interesting about how you're going to incorporate this study into clinical practice. I don't think I'm going to do MRIs routinely in patients who I suspect may have endocarditis. However, it makes one wonder if you're going to be sending a patient off for surgery, if you should do an MR on general principles. It's also uncertain in my mind whether or not you should go looking for aneurysms. It's been well known for years that patients have silent aneurysms, and if you treat the patient, they usually don't bleed. So it makes one wonder if they needed to have embolization as they did in this trial. So I don't know, or je ne sais pas. I'm not certain how relevant this is to the day-to-day practice of infectious diseases and the treatments of endocarditis. Food for thought. An interesting study on the treatment of chlamydia-induced reactive arthritis. Patients were randomized to get either doxycycline plus rifampin, azithromycin plus rifampin, or placebo. And they found that patients who had a long course of antibiotics had better outcomes with their chlamydia-induced rheumatoid arthritis. Why might that be? Are they treating an infection? Au contraire, mon frère. Remember how we talked earlier in this study about how minocycline decreases the inflammatory response of T cells, and how I've been harping over the months about how macrolides are beneficial because they are immunomodulators? Bet you nickel that the effect of the antibiotics here is less on the treatment of a chronic infection and more due to the immunomodulatory effects of macrolides and doxycycline. This is especially of interest because it was the azithromycin group that had the better effect rather than the doxycycline group. Although in favor of treating an infection was the fact that they used a PCR looking for the presence of chlamydia, and those that responded had a disappearance of their chlamydia PCR. I'm still going to put my money on the immunomodulatory effects of these antibiotics. We often think that if a patient survives their hospitalization, all well and good, you don't need to worry about things long term. However, getting an acute severe infection is a bad thing. It's associated with increased rates of myocardial infarction, stroke, and pulmonary embolism. The risk can extend out to a year after the acute infection, and that probably applies to mortality as well. This looked at the long-term survival of hospitalized patients who had community-acquired pneumonia. And even after adjusting for comorbidities and age, having community-acquired pneumonia was associated with an increased mortality for the next year. This has also been shown to be true for people who get, for example, sepsis and end up in the ICU. Acute infections are bad predictors of short-term mortality up to a year. And how to alter that mortality is as of yet unknown. But just because you have pneumonia and you skip out of the hospital doesn't mean you're scot-free. Maybe the answer is steroids. Isn't the answer always steroids? However, this study looked at patients in the VA population who were admitted with pneumonia and COPD. These are all over age 64, and they looked at mortality, and they found 6,300 patients who had pneumonia and prior COPD. Of these, 38% were on inhaled corticosteroids. They found that mortality was 9% at 30 days and 16% at 90 days, again showing that pneumonia is a bad thing in an elderly population. However, outpatient inhaled corticosteroid therapy was associated with a lower mortality at 30 days, odds ratio of 0.76, and 90 days, 0.80. So perhaps the secret of treating pneumonias is to put patients on inhaled corticosteroids. Now, this is not a causality study, and this is like statins, and that prior treatment with statins decreases your risk of dying of a variety of infections. Perhaps everyone needs to be on aspirin, statins, and inhaled corticosteroids. It's probably a little excessive, but far be it from me to have moderation, you know? Oh yeah, as an aside, whether you do your trach early or do it late doesn't make a difference in your hospital-acquired pneumonia rates, according to a randomized study out of Italy. One of those mystical phrases that people use is double coverage. Big gun strong, double coverage. Do you need to double cover people with antibiotics? Well, most of the time the answer is no, but one time where it's probably of benefit is in severe sepsis. Now, this was a retrospective analysis that looked back at 760 patients who had severe sepsis or septic shock and had gram-negative bacteremia. Well, not unsurprisingly, if you got the wrong antibiotic, your mortality rate was over 50%, compared to 36% of those who got appropriate antibiotics. However, if you had a combination therapy, you were less likely to die than if you had monotherapy. So a beta-lactam plus an aminoglycoside had a 22% death rate versus 36% for the monotherapy. In their study, they found that the use of a beta-lactam plus an aminoglycoside was better than a beta-lactam plus a quinolone, probably because of the amount of resistance to quinolones in the community. So this would be yet another study, all of them retrospective, that suggests at least for severe sepsis due to gram-negative bacteremia, a beta-lactam and an aminoglycoside is the way to go. And that's been my message for 25 years, so it's nice that it continues to be validated despite the fear many people have of aminoglycosides. However, remember, it's the first dose of aminoglycoside that's probably the most beneficial, and you can't get toxic from a single slug of Gent or Tober or amikacin. It's not pharmacologically possible. And so what do you do with severe necrotizing pancreatitis with infection? I mean, you got to drain the pus, but surgeons don't like to go near pancreatic infections, and I don't blame them. This was a study in the New England Journal of Medicine. They randomized 88 patients with necrotizing pancreatitis to either go an open necrosectomy. There's a word I haven't heard before. necrosectomy. I guess they just scooped out all the ooky pancreas. Or a step-up approach, which consisted of first a percutaneous drainage and then a minimally invasive retroperitoneal necrosectomy. And they found, and I shall quote the conclusion, quote, reduce the rate of composite endpoint of major complications or death, as well as long-term complications, healthcare resource utilization, and total cost among patients who had necrotizing pancreatitis and confirmed or suspected secondary infection. So the step-up approach is the safer way to go. And if you listen carefully, you'll hear a bunch of surgeons sighing with relief. Mesotherapy, I've talked about before, is a form of quackery where they inject you in the superficial layers of your skin with a variety of garbage in an attempt to make you look purty. Doesn't work. It does, however, inject infections with it, and there's another outbreak of Mycobacterium fortuitum, this one in La Rioja, which is a delicious wine, part of Spain. 138 women had mesotherapy, and 28% developed lesions due to Mycobacterium fortuitum. They'd have anywhere between 3 and 20 indurated erythematous papules that went on to become fluctuant boils with suppuration, fistulization, and scarring. Listen, mesotherapy doesn't work. It is garbage, and it's only going to give you a risk for an infection, and it ain't going to make you look purty. So often when I see travelers who come back from malarious countries, they said they had a fever, and they were immediately treated for malaria. How good is fever as a sign of malaria? This study comes out of Africa, and they had 16,903 children who were surveyed for malaria and fevers. You ready for the numbers? 76 were neither infected nor febrile. Great. Here's the interesting thing. 3% were febrile and infected with malaria. 9% were febrile but didn't have malaria. And 12% had malaria but were not febrile. So the presence of fever is neither a good indication of malaria, and the absence of fever is not a good indication of malaria. Something to keep in mind. Now, this isn't a population of children who live in malarious areas, which is obviously different from people who get their first exposure due to travel. But still, the presence of fever does not mean malaria. The absence of fevers does not exclude malaria in patients who live in a malarious area. I'm starting to sound like Dr. Seuss there. And now your favorite part and mine, the hodgepodge. No references will be put in the show notes for the hodgepodge. So, if you're going to Norway, don't have sex with men. Syphilis is increasing in incidence in Norwegian men who have sex with men. Animals are not protective in juvenile arthritis. Huh? What a headline. Well, the thought is that kids who are not exposed to filth are more likely in life to have autoimmune and allergic diseases. So they looked at kids who live in rural areas who had consistent exposure to farm animals and found that being around pigs and goats did not protect them from developing juvenile rheumatoid arthritis later in life. Here's one. Fire hot, water wet. Prior use of antibiotics decreases the chance of yielding an organism in prosthetic joint disease. Who would have thought that antibiotics would decrease your culture yield? Interestingly, adults who are around kids who get the pneumococcal vaccine are at lower risk for developing bacteremic pneumococcal disease. And the pneumococcal vaccine has cut disease rates in half in Navajos. Pretty good, given that they get lots of invasive pneumococcal disease. Now, here's a big surprise to me, quite frankly, which is that ICU care for the uninsured is both less intense and has poorer outcomes. I've never noticed that in my hospitals, but it could be a marker that they came in more ill, which is why they had a higher mortality rate. But still, having no insurance has always been associated with shorter lifespans in the United States. It's why in the United States, healthcare is second to none, because we're 17th. Steroids add to mortality of C. diff infections. No surprise there. And if you're going to do a transrectal prostate biopsy, and if you do, don't name it after me, quinolone-based antibiotics are the best prophylaxis. Interestingly, the use of statins was protective against the development of Candida infections in patients who are hospitalized with diabetes, which I think is interesting given that statins are shown to have increasing benefit in the prevention of mortality from infectious diseases. It's interesting that it also decreased the development of Candida infections and colonization. Toxoplasma can reactivate after myeloablative therapy in patients undergoing allogenic hemopoietic stem cell transplantation with a rate of approximately 8.7%. Cyclosporidia in Istanbul, Turkey, occurs most often when it is dry and warm. I always find these infectious diseases associated with the weather to be interesting, and here's yet another example how local weather will alter the rates of infectious diseases. And that ends our hodgepodge. Wait, you're not done. Now that you've listened to this, you have two things to do. One, go onto iTunes and write me a glowing review. My fragile ego demands it. Or is it my ravenous ego? My fragile, ravenous ego demands it of you. Also, now that you've done, go and take the CME quiz. Get a half an hour of free CME. Thank you, Legacy Health. And this ends yet another in what seems to be an endless series of Puscasts. The references are online. This has been brought to you by Pusware LLC, publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. your uber hyper linked electronic guide to infectious diseases, available at moremark.squarespace.com and available as an iPhone, iTouch, and iPad application. And don't forget to participate in my growing multimedia empire. There's the Quackcast. There's Rubor, Dolor, Kalor, Tumor, my ID blog over at Medscape. There is Agavado Pus, my other infectious disease podcast. And finally, Science-Based Medicine, where I blather away every other week on all things scams. Because the world needs more Mark Crislip. This is copyright under the Creative Commons license. The music is by my son when he was 12, improvising on the guitar. Go ahead and email me. I'm never going to answer it. I got too much to do. Sorry. But thank you for listening. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.